Good afternoon, everyone. Yet another session of Nursing Academics webinar today. And I would like to have a small announcement. This whole June month, we will be running the academics webinar on OBG and Gynec series. As we understand, we nurses, as a bedside nurses, we would like to learn a lot of procedures about the OBG and Gynec series. And we would like to hear from our eminent speaker and the panel expertise, who is expertise is Dr. Sharada. Let me welcome Gayatri as our speaker today, and let me also welcome Dr. Sharada, who is our eminent speaker. I can see Dr. Sharada, she's busy since the whole week, and I thank you, ma'am, that in spite of your busy schedule, you have come for this session. Thank you so much. And today, the topic which I'm going to talk on, or we are going to discuss on preeclampsia, overview, and nursing management. As we all know, one cannot ignore women's reproductive health because women or female is very precious gift to the God. Let us see the overview of preeclampsia and eclampsia and correlation connectivity with the maternal morbidity and its mortality. Over to you, Gayatri.
Thank you, ma'am. Let me share my screen. Good day, everyone. I'm genuinely excited about the topics we are going to explore today. I look forward to sharing my insights, engaging in insightful discussions, and learning from you all as well. Together, let's make this webinar a truly enriching experience. Today, we are going to discuss about eclampsia and preeclampsia. Hypertension is the most common medical problem we have been encountering during pregnancy, which is complicating 2 to 3% of pregnancies. There are different types of hypertensions during pregnancy. That might be chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia. So all hypertensive patients should undergo increased surveillance and serial laboratory investigations throughout the pregnancy. So today we are going to deal about eclampsia in detail. What do you mean by eclampsia? Eclampsia is onset of seizures in a pregnant woman with preeclampsia, and these seizures were not related to any kind of brain conditions that patient is already having. So for the eclampsia to happen, the pregnant lady should be a preeclamptic. What do you mean by preeclampsia? It is a disorder of pregnancy where there is high blood pressure and often a significant amount of protein in the urine. What do you mean by high blood pressure? So the blood pressure should be about more than 140/90. So why is this preeclampsia or eclampsia is so much important to discuss, or why do we need so many investigations? Why we have to screen the patients is that this preeclampsia is a pregnancy specific disorder which affects 2 to 8% of all pregnancies. Imagine in 100 population, it may affect 2 to 8 mothers. So it's really important to talk about this condition. So this is leading and maternal and prenatal morbidity and mortality leading cause worldwide. So for this, there are few diagnostic investigations that we have to follow up. And obesity is standing the increasing alarm reason for preeclampsia. So when you look at the image, it says United States is having 16% of maternal deaths due to preeclampsia, which is a huge number, and 10 to 15% of maternal deaths are due to preeclampsia.
Hang on. So, Gayatri, we would like to hear from Sharada ma'am that how do we assess the pregnant woman for eclampsia, as we are going through the prevalence that it is more than 25% of women who contracts this preeclampsia, and which trimester of pregnant woman is more affected with this condition, as per your view?
So these are two things, Shanti, preeclampsia and eclampsia. So if we call eclampsia, yes, see, preeclampsia we call only after 20 weeks of pregnancy. It usually arises after 20 weeks. So before 20 weeks, if the woman is having blood pressure, we call it a chronic hypertension.
Yes.
We do not call it preeclampsia. So after 20 weeks, we call it preeclampsia, and if seizures do come, we call it eclampsia. So eclampsia can come even when the woman is pregnant, antepartum, during labor, intrapartum, and also postpartum. Post-delivery also women can have eclampsia.
So very good thought about it, because we nurses, we always generally term it as eclampsia, and but there is again significant difference between preeclampsia and eclampsia as well. So as Gayatri was talking about her slides, that as a leading cause is obesity for eclampsia. Is it a true statement, ma'am?
Yes, definitely is. Obesity definitely increases the risk of hypertension, which in turn increases the risk of eclampsia.
Thank you. And generally, yes, it correlates between eclampsia and obesity. Thank you. Please continue, Gayatri.
So what are the causes that is leading to preeclampsia or eclampsia is that during normal placental implantation, these cytotrophoblasts migrate into maternal uterine spiral arteries, and that will help for the nutrition of fetus or the implantation of placenta. But during this eclampsia or preeclampsia, this system process does not happen properly, which leads to placental ischemia. As we have discussed, obesity is really a leading factor for eclampsia, preeclampsia. That's because when the mother is gaining excessive weight, there will be insulin resistance in the body, because of which this extreme insulin resistance will lead to reduced cytotrophoblast migration, and again leads to placental hypoxia.
So, Madam, again over to you, that the causes which Gayatri has discussed, do you think, ma'am, these are only the scientific causes of preeclampsia, or these 4 causes are enough to, diagnose with the causes of preeclampsia?
Yeah, so to answer this question, I have to make you understand the normal physiology of how the placenta develops. Okay, so when the placenta is developing, the mother's blood vessels go into the fetus blood vessels, and the blood vessels become very dilated and very soft. So they are not like the mother's blood vessels, they are not resistant. So we call that decidualization. So decidualization happens in 2 phases. First, from 12 to 16 weeks, second wave from 18 to 20 weeks. So the decidualization makes the placental, the mother uterine vessels, whichever are supplying the baby, very soft. So a lot amount of blood flow can go to the baby. So in preeclampsia, this decidualization doesn't happen. So the prostaglandins, some immunological factors, they derange this decidualization and the blood pressure builds up. I think it's not so clear, but
Yes, so
decidualization, if it doesn't happen in the first and second phases, that means within 20 weeks, if it doesn't happen to any pregnancy, then the preeclampsia develops after 20 weeks. So mostly these immunological mediated factors will place the women at a risk of preeclampsia.
Okay.
Of course, the other things like obesity, the hypertension, the other factors increase the risk, but it's mainly an immunological factor.
So how do you differentiate a hypertension from preeclampsia is that always the systolic blood pressure should be more than 140 mmHg and the diastolic pressure should be more than or equal to 90 mmHg. One reading of blood pressure is not taken into consideration. You always should have a standard of 2 readings, and the gap between 2 readings should be 4 hours apart. For example, if you are checking the blood pressure at 1 o'clock in the noon, again, please check with a 4 hours apart of 5 p.m. again, and then it has to be taken into consideration.
So my little worry on when we try to educate the mother who is a primary mother and who is from the community based or primary health center based or from the urban area, rural areas, how they should know what education we should give to them. Like they may not know the the concept of checking the BP with the real manual sphygmomanometer kind of process, and if they are not educated, how one should write the readings, or if the entire family member is not educated, and what when they come next to the antenatal checkup, what information they should give. BP is shoot up, or BP is low, or BP is normal, ma'am. So maybe you will be witnessing a lot of such patients. So how do you educate them, ma'am?
So nowadays, the community-based screening for preeclampsia has picked up. WHO, PIGO, all the international bodies are asking us to do a community-based screening and increase the awareness. As you have told, we never know when the blood pressure increases. So the initial signs will be puffiness of the face, puffiness of the hands. See, swelling in the legs is normal thing, but sometimes it can be pathological. If the woman is gaining a lot of weight, lot of water retention, approximately 4 to 5 kgs in a month, the weight change is very huge, there's a lot of swelling, then we say that the woman might be developing blood pressure. If not now, maybe some 2 to 3 weeks later, she might be developing blood pressure. And otherwise, they get that headache, clarification, that is in eclampsia, severe preeclampsia. But initially, when a woman becomes pregnant, nowadays we have a lot of screening strategies for preeclampsia. The screening, how do we do? One is just asking her if she has any of the risk factors. What are the risk factors if the mother or the sister has a preeclampsia in her pregnancy, or if she has hypertension in the pregnancy, or any autoimmune disorders like SLE or any other autoimmune disorders, any diabetes, multifetal pregnancies, if her age is more than 35, if she is very obese, even the small girls, sometimes very teenage pregnancy. So any of these risk factors are there. And the mean arterial pressure. So the mean arterial pressure is more than 90. So we have to calculate the mean. This is all in the first 3 months, first trimester.
Yes.
So any risk factor, mean arterial pressure is high, then we give her we say that she is at increased risk of getting preeclampsia.
So ma'am, do they follow the compliance on the certain types of education which you have already given on the first visit of your patients? So do they follow the compliances? I think
definitely
that
yes.
is.
So nowadays we say that preeclampsia, the hypertension, most of them do know because the consequences of hypertension to them, to the baby, and the eclampsia. So they are much aware of those things. So they are they are compliant with the screening strategy.
That's amazing.
So let us talk in detail about the risk factors. So what are the risk factors for this preeclampsia? Is past history of preeclampsia. If mother have already delivered a baby having this disease condition, again there is a chance of reoccurrence. Pre-existing medical conditions like diabetes and multifetal pregnancy like twins and triplets, nulliparity, carrying the baby for the first time, autoimmune disorders like systemic lupus erythematosus and rheumatoid arthritis, family history of preeclampsia, placental disorders, advanced medical age, and use of any assisted reproductive technology. So these are supposed to be the risk factors on the top for preeclampsia. So how do you
before Gayatri, before we were talking about, just go back to the earlier slide, the previous slide. Yeah, before you have discussed a lot of other risk factors which already Shada Madam has already spoken and highlighted about it, but the concern about the nurses' knowledge on and what could be the autoimmune disorders, ma'am?
Yeah, autoimmune disorders like SLE, systemic lupus erythematosus, any rheumatoid arthritis, or any ITPs. ITP, yes. All these autoimmune disorders do increase. Any condition where the kidney is affected, any renal glomerulonephritis, anything where the kidney is affected, they are more at SLE also when the kidney is affected. Diabetes,
it's autoimmune related.
And there is an increased chance of preeclampsia.
And what is the placental disorders and how the use of technology has, contributed a lot of compliance in terms of reproductive health and its management?
Placental disorders can be this placental abruption or a small placenta when IUG have placental infarctions. All these can increase the risk of preeclampsia. Assisted reproductive technologies, yes, the IVF pregnancies, there is an increased risk of preeclampsia.
Thank you. Gayatri.
Yes. Then what do you think are the signs and symptoms of pregnancy, preeclampsia? How do you diagnose, or when you assess the patient for the first time in IP basis, what are the symptoms that patient will be throwing? Is proteinuria, leaking of protein in the urine, thrombocytopenia, reduced platelets, elevated liver function test, and mother might be in severe conditions untreated. Mother will be having severe headaches, tachycardia and tachypnea, and mother will have pain in the abdomen, in the upper epigastric region, and a tendency of vomiting, nausea, and because of there is a lot of fluid shift in the body, there will be generalized edema, that is puffiness, as we discussed before. So When do the symptoms throw up? As we have spoke already before, this can be as early as 20 weeks, and often the symptoms also can begin after 34 weeks. In few cases, there also can be increased preeclampsia, usually after delivery, and they tend to go away. So how do you diagnose, or what are the screening modalities you use to screen the mother? And for the early detection of preeclampsia is frequent blood pressure monitoring. As ma'am has discussed, you have to calculate mean arterial pressure. It should never be high. Urine from the protein. Usually the protein, there is no protein loss in the urine. The normal value is less than always 100 milligrams per day. And if mother is losing so much of protein, that has to be checked. So for this, urine dip test can be done, and 24 hours urine sample can be collected and can be checked for the urine protein values. And we also have to check for placental growth factor in the blood, renal function test for the creatinine in the blood. Usually the creatinine should be 0.0 mg per dl, but then during pregnancy, it will be always less than 0.8 mg per dl. If mother is having higher levels of this creatinine, it indicates that there is an involvement of kidneys because of this continuous increased blood pressures. We also have to check a low platelet count is there or not. Liver function test has to be checked. X-ray for pulmonary edema has to be done, and has to talk to the patient whether how frequent are these headaches for the patient, and are they going away with the pain medication. Usually in preeclampsia, these headaches will not go away with taking the medication. And if not,
Gayatri, just a minute. As we were looking at your earlier slides, so that the eclampsia goes on its own after 48 hours or after the baby is delivered. We would like to also know from Madam, and how the screening of placental growth factor. Can you just put your insight on this, ma'am?
Placental growth factor.
Yes, ma'am.
Shanti, so this placental growth factor is secreted from the placenta. Only in pregnancy we see that. So it has got many functions, like it acts like a growth factor, basically, assisting the growth of the baby, insulin-like factors. So basically it helps in the growth, deposition of fat, and all these things. But we can also use it for screening for preeclampsia. So nowadays we all know about this double marker, quadruple marker, triple marker, right? So
Yes.
we are using those tests for screening of chromosomal problems, Down syndrome and all. So for that we use PAP-A, beta-HCG, alpha-fetoprotein, and estriol. So these are used. So placental growth factor also we can use to screen for preeclampsia. So by using all these three things, we have a software where we can check these hormones, and that software gives us a risk of preeclampsia. So if the risk is 1 in 100, then that is a cutoff. If anything less than 1 in 100, the woman is at a high risk of preeclampsia. More than 1 in 100, she is not at a risk of preeclampsia.
So I think the mother can also well advanced plan her second pregnancy if
Yes.
these precautionary screening modalities are being taken care.
Yes. So if the screening is positive, she has to take aspirin. So 150 milligrams of aspirin is recommended as soon as from the 8th or 9th week of pregnancy till she delivers 36 weeks. So that's the recommendation to prevent preeclampsia in the second pregnancy.
So it is a prophylaxis
Prophylaxis.
regime. Yes. Okay.
so being a nurse, management of eclampsia or preeclampsia during the course of IP is very much important. So what do I do being a nurse is that we have to assess and reassess the antenatal and postnatal periods. We'll discuss in detail how we have to assess and reassess. We have to monitor the patient. As we have discussed before, all the investigation screening modalities has to be followed, and we have to control blood pressure through antihypertensives. Prevention of seizures is very much important, which may lead to maternal mortality. And during the seizures, maintaining safety of the mother is very much important. We shall see in detail in the further slides how to deal with it. And steroids for fetal lung maturity. Observe for fluid balance. Timing of delivery is very much important. Continue vigilance post-delivery. It is not over once baby is delivered, as there is multi-organ effect, or there are many organs involved during this preeclampsia. We have to follow up very seriously after the delivery of the baby, and follow up even after the discharge plays a vital role. So what is a nursing care I wanted to give to the mother is obtain IV access. When you wanted to give any antihypertensives or magnesium sulfate being the first drug of choice during this preeclampsia, we have to access the IV. Place indwelling Foley's catheter, which gives us a gunshot-like rule that whether the mother is having proper urine output or not. If patient is going to anuria or oligouria, it indicates that kidneys are being affected. The reason, and also we have to check the urine for the protein. So for the reason, Foley should be placed. And early intake and output chart is very much important. Vital signs to be checked and documented every 15 minutes for the first 1 to 4 hours. Fetal monitoring to check the fetal compromise. Padded tongue blades has to be kept while mother is throwing the seizures. It's because to prevent the tongue bite. And during the seizures, we have to ensure the oxygenation of the mother 8 to 10 liters per minute. And ABG is also arterial blood gas gives an insight on how the oxygen saturations are for the patient. So once the seizure is stopped or prevented, we have to always collect ABG. Safety in terms of fall prevention, as the seizures are unexpected, they cannot be predicted at what time they happen. So for this, you always have to keep in extreme conditions. Severely sick patients has to be kept on nil per mouth. Adequate rest has to be given. MgSO4 infusion has to be started for the mother for 24 hours. And during when magnesium is being given, we always have to check for the magnesium toxicity. So how do you check for the magnesium toxicity? The symptoms of magnesium toxicity, eat all 4 to 6 grams can be given per day. It usually starts after. So symptoms of magnesium toxicity will be exceeded when the serum concentration of the magnesium in the blood is more than 1.74 to 2.61 millimoles per liter. So if it is exceeding than 1.74 to 2.61, then mother will have symptoms of magnesium toxicity. They can be hypotension, nausea, vomiting, facial flushing, retention of urine. All these can happen for the mother. So you also has to look for HELP syndrome. HELP syndrome, why you have to look is during the involvement of liver, there also can be involvement in the there will be involvement in the hemoconcentration. The hemoconcentration would change and the mother will have platelet counts also will be reduced.
So here, madam, as we have seen, the fetal monitoring is very important, and what kind of teaching you would like to give to the nurses, like fetal monitoring all the time, it is not as per your expectation, because once you come for the rounds, you need to have that graph to look at the fetus well-being. So what is your take on the bedside OBG nurses? So how they should do? Anything else they should do to give you a proper monitoring record?
So the CTG graph is every 4 hours. We don't have to do that continuously. But within that 4 hours, we try to listen to the heartbeat. So most of us have a Doppler in the ward. So if you can check the heartbeat at least once in 15 minutes and write down the rate, how much it is. Sometimes 140, 100. So if it is 100, that means the heart rate is less. The baby is not doing good. So based on the rate also, we can find out whether the baby is doing good or not. Every 15 minutes, if there's a writing of the heart rate, the way you monitor the blood pressure and all, the fetal heart rate also, if you can monitor, that would definitely help us.
I think we all are practicing just taking the graph and escalating to your residence gynecologist, and when you all come for rounds. I think this is very well noted point that maybe perinatal documentation also can be done for the nurses. As you said, if it is below 100, we can always tell the nurses to write in the nursing note to the CTG graphs recording. Yes, thank you, ma'am. Yes, Gayatri.
This preeclampsia can be treated very well in the hospital setting. When this is not treated well at home, it was untreated or neglected, it can lead to few of the complications like prolonged unconsciousness, acute renal failure, cerebrovascular accident, HELP syndrome, pulmonary edema, pneumonia, coagulopathy, abruptio placenta. All these complications may happen. The main reason might be there is a fluid shift and endothelial cell damage happens, and that will affect all the vital organs in the body, accumulating excess fluid everywhere. So, what is HELP syndrome? When it is not treated well in the community basis, it may lead to HELP syndrome. It is a pregnancy complication and is a type of a preeclampsia. It usually occurs during the 3rd trimester of pregnancy. It can also develop after the childbirth. So in this, there will be hemolysis, elevated liver enzymes, and low platelet count. This hemolysis can be because of breakdown of red blood cells and elevated liver enzymes. That is, as I said, endothelial cell damage is there. These endothelial cells are present everywhere in the body. And because of this liver, there will be elevated liver enzymes and low platelet count can happen.
So if we see the women with HELP syndrome, I think as the data says, it is 1% to 2%, or maybe Madam is the best person who would tell us how much percentage are still prevailed in the society or in the community, or they come for the regular checkup. So when we detect the pregnant mother with HELP syndrome, so what will be the treatment modalities, ma'am? Like they need to be monitored in the ICU, or if they're little normal, they can be kept in the what scenario, and a lot of vigilance and monitoring is required, a lot of fluid resuscitation, all that sort of treatment.
HELP syndrome is serious. Severe preeclampsia is HELP syndrome. We cannot keep them in the ward. We definitely have to keep them in ICU monitor, because low platelets is the main thing, hemolysis. So the platelets are going down, she'll start bleeding everywhere. We cannot, and then slowly she'll go into DIC. DIC is more dangerous. So we have to correct her platelets, deliver her baby as soon as possible, and help her body to recover from that. They definitely need to be monitored in ICU.
So the mother who has already got the HELP syndrome prior to the delivery, is there any possibility that she may get postpartum HELP syndrome as well?
When the women gets HELP in pregnancy, treatment is delivery. So that HELP will continue like that post delivery for another 2-3 days.
Okay.
The HELP will not come back again after a week or something like that. So it will be there. Once the woman is delivered and treated, it will not come back.
Yes.
So nursing care is very much important during the for such mothers, during the antenatal period, during the delivery, and also the postnatal. So what are the principles of care that we give after birth is monitor closely in a high dependency area. It doesn't mean once delivery is over, everything will set back to normal. So for 24 hours in a high dependency care area, vitals and all the intake output, what are the parameters that we have discussed before, everything has to be checked. Consider admission to ICU if it is really required, and close monitoring of vitals. Documentation is very much important for the nurses to evaluate the progress of the mother, whether she is recovering or she is deteriorating. So to identify the graphical presentation, you have to always document the intake output chart as well as vitals, and monitor blood samples has to be taken and has to be monitored for platelets, creatinine until they have reached their normal level. Review antihypertensive drugs and anticonvulsant drugs has to be reviewed as indicated by the gynecologist. So how do you prevent? As we have discussed before, vitamins like vitamin C, E, sodium restriction doesn't have any role, or had very minimal role during in preeclampsia. So low molecular weight heparin is a prevention or a prophylaxis. Is low dose of 75 to 160 mg per day can be started before 16th week of pregnancy, and calcium supplement also can be given to the mother.
So I think, ma'am, as the myth of taking the vitamin C doesn't play any role in prevention of eclampsia.
So there were a lot of studies, Shanti, definitely, yes, everybody studied. And in fact, antioxidants, some amount of this lycopene, which are there in tomatoes, vitamin C, vitamin E, lot of studies. So all of them said no evidence. Only calcium, and that is the women is deficient in calcium, taking 1.5 to 2 grams of calcium per day prevents preeclampsia. And aspirin is the only wonder drug which prevents preeclampsia. Only aspirin.
Okay. So this LMWH, the dosage strength factor is fine. What is been seen?
So low molecular weight heparin we give only if the women has this autoimmune disorders. They call as antiphospholipid antibody syndrome. Then only we give heparin. Otherwise, not for prevention of preeclampsia.
No.
So in conclusion, we would like to say that when we use the standardized assessment tools for the surveillance and adequate management is given to the mother during the course of pregnancy, we can always reduce the potential reduce the risk of adverse maternal outcomes in the women with preeclampsia, especially in the community setup. Thank you.
So, ma'am, thank you so much. And we would like to hear the conclusion note from your end only, because I think the infertility prevalence is very, very high. And on the top and over that, if at all, we have women suffering with the preeclampsia or going into a stage of eclampsia, and a lot of perinatal and maternal related pregnancy disorders is the prevalence in the community. So we like to have a good conclusion from you. What should be the reproductive health of women and how she should prevent by not shifting herself into this state?
First thing, plan pregnancies soon. At the reproductive age, don't postpone pregnancies. That's one sincere advice to all
Yes,
working,
yes.
non-working, all women. And understand the risk factors are there. So you understand if there is any risk factor, if the mother has any risk factor, anyone in your family can become pregnant. First, see if there is any risk factor to her where she can become hypertensive. Then she can start the prophylaxis. And
I think yes.
When it definitely does come, it needs a team effort. Proper team should be there to take care. So, and everybody in the team are important. That's how the good outcomes come. Nobody are less, nobody are more. Good proper team with all nursing staff. The doctor is the last person, I think. It's mainly because nurses are always there by the bedside. You're the first people to catch if any imminent signs, headache, vomiting, nausea, anything. First thing to catch is the nursing staff. I always believe that you should understand the signs and symptoms of imminent eclampsia, when to give magnesium sulfate, how to monitor the blood pressure, all these things.
Thank you, ma'am, and thank you so much. We'll continue to have these many more surveys, because preeclampsia is not only one condition. We have many more, and thank you so much. Thanks, Gayatri. That's how we end the session this time, and next Thursday again 3 p.m. we will connect. Thank you, everyone.
Bye.